And on the NYU side, it's led by Kyung and me. So today, I want to convince you that health system scale language models are actually quite flexible as a all-purpose prediction engine in the health environment. So as an outline, there are three parts of the talk. First, I will talk about some backgrounds of our work, like what is Langone like, what is EHR, what is clinical notes, and what is the last mile problem. Next, I will talk about our method that use the pre-training and fine-tuning paradigm. And finally, I will present some of our results and we can hopefully discuss more. On the right, you can see Otto. He's our lab mascot and one of the reasons why we're called the O-Lab. So let's first start with background. So this is the entrance of Langone. It is a multivariate health system with a diverse patient population. It has more than 300 outpatient sites and 3 main campuses in New York. So there's one in Manhattan, one in Brooklyn, and one in Long Island. And I mainly work in the one in Manhattan. And we say the patient population is diverse, as you can see in the pie chart below. So in Manhattan, there is a higher Hispanic, Black, and Asian population than the national average. At Langone, health professionals use electronic health record or EHR to document all clinically relevant information. So for example, here is, you can see the main page of my EHR. You can see useful information like what kind of appointments you have, what medications were prescribed, and what are the test results. And if you click into test results, you can see an example of my chest rate summary. It basically says my lung is okay. And we have a large amount of EHR records available in Langone. So to develop Neutron, we use EHR records from 2011 to 2021. And we did a temporal split to evaluate how well the language model adapts to temporal shift. So we have around 336,000 patients for pre-training, and those patients come from 2011 to 2020. And then for fine-tuning, we added 1 extra year of patients from 2021, resulting in a total of around 413,000 patients. We can also see there are a lot more information in the clinical notes. So for example, in this emergency department notes of mine, you can also see my medical history, my vitals such as heart rate and temperature, and the result of my physical exam. The observation here is that all information is ultimately integrated into the notes written by physicians. They also contain physicians' assessment beyond direct measurements and treatments. For example, the physicians could note that the patients have some weird bruising that might be an indication of domestic abuse. I've also added that. Feel free to interrupt me at any point if you find it confusing. Right, so now we'll talk about the last mile problem. So one might wonder, seeing that EHR has so much rich information, why aren't there any existing commonly used EHR-based prediction model in practice? So So the last mile is going from is actually deploying an EHR-based prediction engine in a real health environment and use the prediction to assist the clinical and operational decision of the health professionals. However, existing structured database model have limited use in practice because there is a lot of complexity resulting from collecting and pre-processing, for example, 300 expert selected structure features, and then adjust for different local units and local thresholds. However, we observe that all those clinically relevant information are actually ultimately integrated into the clinical notes. So we can, instead of working with all those various structured data, we can actually train a language model to read clinical notes. And you might ask, why do we want to train a clinical language model rather than just using a off-the-shelf general language model? This is because clinical notes have their own idiosyncrasies. They are written in medical language. So when I'm working with a clinical note, sometimes I have doubts of whether or not I'm reading English, and I need to confirm with Eric and be like, oh, okay, this is what it means. We also decided to train a clinical language model because we have a large amount of clinical notes from EHR. So we have the data that can enable us to do so. And finally, we go to the last mile by fine-tuning this pre-trained language model with labeled clinical notes to predict a variety of clinical and operational tasks. So let's look at our pre-training corpus. For pre-training, we use around 7.25 million nodes that are collected between 2011 to May of 2020. So those nodes include radiographic reads, medical history, and physicals. And the corpus has more than 4 billion tokens. For our fine-tuning tests, there are 5 in total. So there are 3 clinical tests. The first one is in-hospital mortality prediction. So this is asking how likely will the patient die in the hospital before discharge. Second one is being comorbidity index imputation. So this one is asking if we don't have access to the patient's diagnosis codes, they're called ICD, how sick or chronically ill is the patient. The third one is 30-day all-cause remission prediction. This one is asking how likely will the patient come back within 30 days of being discharged. For the operational task, we have been length of stay prediction that asks how long would the patient stay in the hospital, and insurance denial prediction that tries to predict whether or not the patient's insurance claim will get denied, so that we can work more on the high-risk patients so that they can hopefully get more reimbursement. So let's talk about 30-day remission. This is our main task. For our data, we have labeled discharge notes, where the label is a binary label. If the label is 1, it means that the patient did came back within 30 days, and this includes the scheduled ones. This test is important because it could impact the physician's discharge decisions as well as follow-up care plan. So for example, if we could detect a high-risk patient, the physicians could decide to keep them in the hospitals longer so that we can treat them better, or we can decide to ask nurses to call the patients after their discharge to make sure that they know how to take their medications correctly. For the in-hospital mortality prediction, We collected the history and physical notes. So they're basically notes written at the admissions that documents the medical history and their physical exams. Each note is labeled positive if the discharge disposition is expired. If we find that a patient has a high risk for dying in the hospital, then we could allocate more medical resources to them and hopefully prevent this from happening. For a comorbidity index imputation, our target is a Bing-Charson comorbidity index. And this index is a rule-based index that is calculated from structured data. So basically, the older, more chronically ill a patient is, the higher the index would be. In our system, we don't have this index available, and for physicians to use this index, they typically need to look up structured ICDs. However, for some patients, the structured ICD is also not available. So that's why we're trying to impute this index from clinical notes. Knowing that a patient has a high comorbidity index, this could impact the physician's care and treatment plans for the patients. For the length of stay, we're interested in knowing how long the patient will stay in the hospital after they are admitted. And we bing this length of stay into 4 bings. So the first bing is 0 to 2 days, second bing is 3 days, third bing is 4 to 5 days, and the fourth bing is more than 6 days. And these bings are determined by the quantile. This could facilitate optimizing resource allocation at the hospital because the hospital administrators are basically running it like a hotel. Finally, for insurance denial, we're asking how likely will the patient's insurance claim be denied? Our data is both the history and physical notes and the discharge notes, and we have 2 labels, actually 3 labels. So for the 2 positive labels, we have final adverse determination. So this means that the claim was rejected once and it was rejected again upon appeal. So the result is a final rejection. The second positive label is final favorable determination. So this means the claim was rejected by the insurance once, but after Langone appealed it on behalf of the patients, they approved the insurance and gave the reimbursement. On the negative label, it means the insurance was not denied in the first place. We want to be able to predict insurance denial so that we can reduce unnecessary out-of-pocket costs for the patients and the financial burden on our health system. So now we see a unified approach to our last mile problem. After we pre-train our language model Neutron, we just we fine-tune it with label clinical notes for each specific task. And at inference time, after a physician finished signing a note, it gets sent to Neutron. And the Neutron will output a probability, predicted probability for the interested events, such as insurance denial, mortality, or readmission. And given this information, then the administrators and the physicians can continue to make their decision. So that's all our backgrounds. Is there any questions before we move on to the method? Yes, Alex.
Just a quick question for the deployment step after you fine-tuned. Do you have here 5 different models for each of these 5 tasks, or like is this, do you basically fine-tune just one model 5 times and then use the same weights actually for each of these prediction tasks?
Oh, that's a good question. Yes, so for deployment, the plan is to use separate tasks. And for clarification, for right now, we only deploy readmission task. Does that answer your question?
Yes, but I was also wondering whether your NYUTron is just one model, or whether there's actually like a version for each of the specific tasks. Like there's one NYUTron for the readmission prediction, and then like for the I don't know, for the insurance claim prediction topic, you have like a different model, which is like the same architecture, but just like after fine-tuning with like slightly different weights.
I see. So after pre-training, they're all the same. And then using the same pre-train model, we fine-tune on separate tasks separately. So there's neutral readmission, neutral mortality. Does that answer your question?
Yeah, thanks.
Yeah, you're welcome. Yes, Ahmed.
Yeah, so for the hospital readmission, are you predicting unplanned readmissions only, or are you also predicting the scheduled ones?
Good question. So the ones that are penalized, so only the unplanned ones are penalizable. So in the ideal case, we want to predict only the unplanned readmission. However, in our health system, in our EHR, we don't have this label. So instead, we're predicting all-cause readmission and leave the and then so basically, if a physician is alerted that there is a risk for all-cause readmission, there is a chance that this remission will be unplanned. So then it's up to their determination to determine if they want to do something about it. So basically, we want to be able to predict it in the ideal case, but because we don't have the label to fine-tune it, so we're not doing it.
And when you say all cause readmission, do you mean planned or unplanned, or is there a clinical cause for readmission?
All cause, right? So sometimes patients come back because they are scheduled to come back. What we care most about is when patients are not scheduled to come, when the remission is unplanned. For example, if a patient was sent home because we thought we cured them, but then they come back because they weren't actually cured, then this is problematic, and maybe we shouldn't discharge them in the first place. So we included this type of readmission, but we also included the readmission where the doctor said, "Oh, come back in 7 days." Admittedly, this label is noisy, but it's a limit in our EHR because we don't have the label for whether or not it is unplanned.
Yeah.
Does that answer your question?
Thanks.
Thank you. Eduardo, did I pronounce that correctly?
Yeah, this is just a small clarification. So for readmission, that means that if the patient came to the emergency department and was not admitted to the hospital, you're not counting those encounters, correct? Or is any encounter in the ED?
Oh, good question. So for our readmission test, we included not just the notes in the ED, but all hospital admissions. So that would also include, for example, patients with brain tumor that needs to stay in the hospital for surgery.
Right. Okay.
Does that
But it's
answer your
only
question?
those that are admitted. Yeah, because
Yeah.
Speaking about brain tumors, like if you have a patient that, for example, has nausea and they just come to the ED and the nausea resolves within the 2 hours of visit, you're not counting those as readmissions, correct?
The nausea is so basically we need to check if there is a separate admission within 30 days after they're being discharged. So if the patient's nausea is resolved after 2 hours and then they're good and they went home and they never came back within 30 days, then we do not count it as a readmission.
Okay. Thank you.
Yeah. You're welcome. Cool. So I guess we can move on to our method. So our Neutron is a BERT-based model, and it's relatively small compared to all the other large-scale work going on right now. It has 109 million parameters, and the vocab size is 50,000 tokens. The maximum sequence length is 5 to 12 tokens, and we split nodes into and for long nodes, we did truncations. We also experimented with splitting long nodes into non-overlapping chunks and then just take the average of all those chunks. The result was minimal, so we decided to just keep the truncation instead. And sorry, this is a correction. We used an LTK to ensure that sentences are not split across the chunks. So for pre-training, we use mass language modeling. So basically, the mass language modeling scheme is saying that if I mask out a token, would you be able to fill in that mask tokens based on the other context? And we pre-trained our BERT model using 24 A100 GPUs over 3 nodes for 96 epochs, which is around 3 weeks. And we decided to stop afterwards because the validation loss plateaued. We use zero optimizer. We use zero redundancy atom optimizer to speed up the training. And we also use mixed precision to speed up our training. For fine-tuning, we attach a linear classifier at the end of we basically replace the MLM head with a linear classifier for each task. The paradigm is very close to the original BERT paper. For deployment, we use NVIDIA's Tricon inference server, and it has a cute name, Nutrition. In our real deployment happened between January and April of 2022. It has around 29,000 discharge encounters with around 3,000 patients. And we found that and we had a physician panel to manually review all the readmissions. We found that among the unplanned readmissions, around 20% of them experienced an adverse event or death when they came back. And according to our physicians, among those who experience adverse events, around 50% are considered preventable. And the figure here is again illustrating our deployment pipeline. So when we conducted this prospective trial, when the physicians finish signing a discharge note, it immediately gets sent to our inference server Neutron, and Neutron would will output a prediction. So if this prediction is above our threshold, then it will send an email to our development team. For evaluating, we have 4 types of evaluation. The first one is retrospective evaluation. So basically we have, so you can see between January 2013 and May 2021, we split this notes from this time into train, validation, and test split. So basically everything is in sample in terms of time. The second type of evaluation is temporal evaluation. So this one is used to mimic the deployment scenario where the test set actually comes from the future of your training and development data. So in our temporal evaluation, while our model was trained and validated using data from January 2013 to May 2021, the temporal test data comes from the future of that, which is June to December of 2021. And then the prospective trial that I just mentioned is an observational prospective evaluation. So basically, after we did the retrospective evaluation, we fixed our model and deploy it in the wild daily. So in this case, we can cheat because we fix our model, and we just observe how it performs in the wild. In the future, we would like to do an interventional perspective evaluation. And so, for example, if a patient is marked as high risk by our model, we could ask nurses to call them and see whether or not with this intervention, we can actually reduce the readmission rates in our control group. So this is our method. Is there any question before we move on to the results? Yes, Ahmed.
So you didn't like for your evaluation, you ran an observational prospective trial of the algorithm. Like you didn't randomize across patients.
Yes, I ran an observational one.
And like if you are to run like a trial, like you randomly assign the algorithm to some patients, what would this entail? Like is this going to be more difficult than the observational evaluation for some reason? Like do you need to get some approvals? Are there like ethical concerns?
Yes, definitely. I think designing a randomized control trial is a little tricky in practice. So right now we're just saying, oh, we evaluate the AUC or the precision and recall when we fix our model in practice. But for a randomized control trial, our hypothesis, rather than having a good AUC or like precision and recall, our hypothesis is that intervention based on our model's prediction would be useful. So then we need to consider counterfactuals like what will happen to the patients if we did not actually intervene with them. And in this case, achieving a good counterfactual is difficult because sometimes it's hard to find patients with like exactly similar conditions. So the design of the randomization and the control group needs to be carefully considered. Does that make sense?
And like for the observational, like you didn't look at patient outcomes before and after the model. You are looking at accuracy.
Yes.
Okay, I see. Thanks.
Yeah, you're welcome. Yes, Eduardo?
Yeah, my question it goes along the same lines. Because so right now everybody gets, or all the physicians get to see your prediction, or what do you mean by observational? I'm lost a little bit there.
Yes, good question. So by observational, it means that we basically deploy it silently. So as mentioned before, we tested our mechanism. So basically we could send the prediction to the physicians, but we're not doing it currently because we're not sure that it actually works in practice. So we thought it might be irresponsible if we directly started intervention before we have actually run a silent deployment. So basically by observational, it means that we had this deployment framework in place and we collected all the data when we ran the prospective trial. But the prediction, instead of going to the physician, it actually gets sent to our database, and it is stored in our database. So after the trial ended, we then look back at the prediction and see if it broke. And what we observe is that, okay, the performance seemed consistent in the prospective trial as the retrospective trial.
Oh, I see.
Yeah.
Yeah. I think that the issue with that is that Yeah, and speaking about actually counterfactuals, is that you can see how different predictions can change over time. Like, for example, if you were to evaluate January 2020 versus March 2020, even if you're doing a silent deployment, because that's, March is when the lockdown started, especially at NYU, you can see how you're never going to get those counterfactuals because of the time issue, right? So I'm curious on how you solve the time component.
That's a good question. So basically, here we're not claiming anything causal. In our observational study, we just want to see, we're not claiming that with neutrons, if we intervene based on neutrons, we're not claiming if we intervene based on neutrons prediction, we can actually reduce the reemission rate. This is our hypothesis, but we're not claiming it and trying to scientifically prove it here. Our hypothesis is that neutron will have good performance, good predictive performance in the variety of tasks.
Okay.
Does that answer your question?
Yeah. Thank you.
Yeah, you're welcome. Yeah, so RCT is our future works, and I think something people that everyone cares about. So I think our current results shows promises, but in order to claim something more causal, we need to carefully design the RCT. Cool. Let's go into the results. So let's first look at the importance of temporal split. Basically, we saw that when we evaluate using the random split, it overestimates our prediction performance significantly. So on the left, you see the AUC of different pre-trained language model when they are fine-tuned on the readmission tasks. And then the x-axis is the number of training examples, number of fine-tuning examples. So basically, we saw that the curve on the left is higher than the curve on the right. And the curve on the left are the result of same time tests. So the test data comes from the same time period as the train and development data. But on the right-hand side, the test comes from the future of the train and development data. So there is a gap between them. And this is, so we see that it is difficult to adjust for temporal shift.
Can you explain what the different models are here?
Yes. Jiang, yes. So this one, the teal line is Neutron. So Neutron is a BERT model, around 100 million parameter BERT model, pre-trained using 10 years of clinical notes from Angle. The orange line here is bioclinical BERT. So it is initialized from BERT, and BERT was pre-trained using WebWiki. So basically Wikipedia and things on the website, things on Wikipedia, and then on PubMed, abstracts. So I call that biology papers, and then clinical notes from Mimic. And then the blue line here, it's BioBERT. So it is like bioclinical BERT, but without the clinical components. The pink line is BERT. So it's just trained using Wikipedia and then the web text. The green line here is a randomly initialized BERT. So we did not pre-train it, and we just directly fine-tuned it using the reemission dataset. For the yellow line, it is a structured data-based model. So it is using a set of expert selected structure feature called LACE, and then it was trained using XGBoost.
Does that answer? How many features does? Yeah, that's great. How many features LACE taken?
you're asking how many features does LACE take?
Yeah.
Yes, so LACE takes in 4 expert selected features. So it's an acronym. The L stands for length of stay, A stands for acuity of readmission, C stands for the comorbidity index, so like how chronically ill the patient is, and then E stands for how many times has the patient been in the emergency department in the past.
I see. Okay. So did you guys do a, I don't know the right word is there, but more fair comparison where there are even more structured clinical features in, like, say, gradient boosted tree?
I see. One reviewer also raised this point. So we use LACE because it is a really common or like mostly used benchmark data set, feature for readmission. And then of course we can use more structured data for the structured data comparison. But it is, how do I say, there are also a lot of other structured database clinical prediction model, but the one main reason why they're not used in practice is because sometimes they're taking too many different structured data, so that the process of collecting all of them and then separately process each type of feature and normalize them is very overwhelming, so that they are not used in practice. So here we're not claiming that Neutron is the best readmission model in the world, but rather it is deployable, and that it is very flexible for a variety of tasks, and that it has good performance as measured by basic structured data baseline. Does that answer your question, Jean? I think your connection is a little unstable, but I think you're saying thank you.
I think so.
Yeah.
Okay,
You're
cool.
good. Sorry.
Yeah, no worries. Cool. So I guess I can move on to the next slide. Okay, so we also did a comparison between Neutron and the physicians. So we surveyed 6 physicians at a different level of seniority at Langone, and actually gave them 100 discharge notes, but I guess they're really busy, so they only did 20 discharge notes. So we compared the false positive rate and the true positive rate between Neutron and physicians. So the green circles here are the physicians, and then the orange triangle here is Neutron, and the blue triangle here is the median physician's performance. So we see that Neutron has the same false positive rate as the median physician, but it has a higher true positive rate than the median physicians. However, it is still worse than the best physicians up here. We also compare clinical notes versus structured data baseline across other tasks. And for all of them, we use a set of expert selected features as established by previous works. And then we train them using gradient boosted tree. So we saw that Neutron with clinical notes outperformed the structured data baselines in all 5 tasks. So apart from accuracy, better accuracy than the basic structure baseline, we also see that we have a unified representation that directly goes from medical language. Whereas for the structure baseline, because I implement them, I need to painfully go through the EHR to collect like 20 different structure data and then normalize them and pre-process them. So here you can see the comparison of the green bar and neutron and the gray bar, which is the structure features baseline. Yes, Ahmed.
So, like with this significant gain, did you look into like what are the predictors in the clinical notes that are missing in the structure data? Because there must be like some variables in the notes that are not traditionally looked at as risk factors for readmissions, or you didn't include in the structure data. So did you like discover any new predictors for readmission?
Oh, did I discover any new? Yes, I did look at attention weight for some readmission notes, but I don't. I don't think I have. I didn't do it very systematically, so I think I can claim I actually discover a new predictor. But it's a good suggestion.
It's not easy because you're learning these embeddings. You don't have like a clear way to disentangle like what predictors are contributing to.
That's true. Yeah. I did look at I did an analysis. I don't know if I have the word cloud. So I did a word cloud analysis of the readmission test based on the log odds ratio, and I can give you some intuition, although I can't like scientifically claim anything. So one surprising fact was that for the patients that did not get readmitted, a word appears a lot, which is friends. So it appears that they have friends who pick them up and will take care of them after they are discharged. So the social factor I felt like was not usually considered in other models.
Yeah, that was my hypothesis. That's why I'm asking.
Yeah. Yes, Eduardo?
Yeah, in your unstructured data, do you also include other features of the, so it goes a little bit on the same line as Ahmed's question. Did you include other features that are pertain to the note? Like, for example, the physician who wrote it, or the specialty of the physician, or how many notes a patient has, or the word count for a note? Because I could think that if a physician is worried about a patient, they're going to be a little bit more detailed on writing symptoms or something. So I wonder if that was included, or that's something that could improve the model.
I see. So right now we did not include any additional structure data in our notes. Yes, but I think it's reasonable to hypothesize that it would help improve the model.
Right.
Yeah, given that we carefully selected information that we think are useful. Yeah.
Right.
Thanks. That's a good point. Ooh, I think I'm running out of time. So I have so many results. Let me think about what are the most interesting ones. Yeah, I'll try to go faster. So this plot is showing you that another advantage of clinical notes versus structured data is that clinical, when we fine-tune language model rather than using structured database model like XGBoost, it actually scales better with the data. So you see that when we have very limited number of examples, like 100 examples, our lace-based model is actually the median performance, although very noisy, is actually a bit better than Neutron here, the green bar here. However, as we get more label examples, more fine-tuning examples, you see that Neutron continues to improve, whereas for the structure baseline, the yellow line lace XGBoost, it actually started to plateau. So this plot is saying that when we have very, very limited data, like 100 at the scale of 100 examples, maybe it is more favorable to use structured baselines because we don't have enough label examples to learn from for our language model. But if we have more label examples, it's more favorable to use language model because it scales better with the data. We also see that pre-training data matters. So basically what we found was that, oh, okay, I don't have the plot here. What we found is that among all the language models we tested, for the ones that were pre-trained using clinical nodes, which is Neutron and this wiki bioclinical Gatotron, the ones that are pre-trained with clinical nodes actually have the best performance compared to the ones that were not pre-trained using clinical nodes. I will skip this one. Let me see. So this plot is saying that when we're fine-tuning, if we fine-tune with site-specific data, it will also help. What does that mean? So bioclinical bird was pre-trained using clinical nodes from Mimic, which is from Beth Israel Hospital in Boston. And Neutron is pre-trained using nodes from NYU Langone. So and then when we fine tune and test on the readmission test from NYU, we see that there is a Neutron is better than the bioclinical birds. So this shows that if you locally fine tune a locally pre-trained model, it is more desirable than locally fine tune an externally pre-trained model. So it could be because that the node writing style between Boston and New York is different, or it could be that the patient demographic is different. There is another test where we fine-tune, where we pre-train and where we control our sites between Manhattan and Brooklyn. And basically what we found is that local fine-tuning always helps. This one might also be of interest. So we conducted a physician panel review of the true positive examples predicted by Neutron to assess the potential clinical impact if we had done intervention. So basically, we saw that among 100 examples that were predicted by Neutron, so those 100 patients are basically predicted flag positive by Neutron, and they actually came back. And we were looking at among those ones, how much were actually preventable. So we saw that around 27 of them are actually preventable and penalizable readmission. So it means that if we had implemented intervention, we could have helped those patients from coming back. Further analysis of our remission prediction shows that there are a lot of confounders everywhere. So for example, Neutron is worse at predicting older patients, mostly because they have different base rates of remission. So if we model those base rates explicitly, it might help address the difference. Neutron is also worse at predicting Black patients, and this is not because they are under samples. And we leave further investigations for the future. There is also, as mentioned, as discussed before, time is also a confounder. So here we stratify across the month, and we saw that there is a significant increase until June before there is a sharp drop in July. So we were wondering what caused this drop in July. And it turns out July is when the resident starts in the hospital and they are learning to write clinical notes. the accuracies also vary across specializations. So you see that, for example, Neutron is worse at urology, patients with cancers compared to patients from neurology. Yeah, so that's all I got today. Thank you.
Thank you so much. That's great work and great talk. Any questions from the audience? Okay. Are you planning to run a trial to see like the impact on patient outcomes? Because I think one thing that's may not be clear is like what kind of decisions would be informed by this prediction. So if the discharge team is observing this prediction, like how can they prevent the preventable readmissions? And wouldn't this depend on the cause of admission in the first place? Like for patients with heart failure, they have like a different intervention than patients with other diseases. Would you run this trial for like a specific subset of the population with a specific intervention, or like how are you thinking about the actionable aspect of these predictions?
That's a good point. Yeah, I do think that the intervention should depend on the cause, but but then let's see. But then if we want to do that, we not only need to predict whether or not the patient come back, we also need to predict their cause of coming back.
And that's hard to extract from data, like the cause.
Yes.
Admission. Yeah, that's something that we'll get about.
Yeah, I think ideally we want to do that, but to do that, we might need to think more carefully about how we can get labels for causes and how to train the model to do that. I think causes, if we think of it as a classification problem, it would be very hard to do because there are so many causes. So it probably shouldn't be a classification problem. Yeah, it's a good question. I need to think more about it. What do you think?
I think maybe one can use a language model to extract at least like approximate labels for the cause of readmission in a completely like just like in a prompt-based way. So like maybe you can look at the notes after readmission and try to see whether this readmission was planned or not, whether it's caused by not adhering to medication after discharge, or try to itemize the different possible causes and then try to use the language model itself to kind of extract approximate labels. And maybe that would be better than having no cause at all, like no prediction of the potential causes for readmission. It would be very hard to validate without having people actually looking into these like pseudo labels. But I think to make like these models actionable, it would be amazing if we can like have cause specific predictions. And I'm not sure like if the data would actually support such a labeling scheme, but
yeah, that's a good point. Eduardo, want to say something?
Yeah, I was thinking when I asked you about the randomized trial, I was thinking on how you could implement it. I mean, and you can implement like a randomized trial based on adaptive randomized trial, you know. But to predict causes now, to add to Ahmed's comment, that's super hard, because then I think that you will need to subset your data also, whether if it's related to something that it was, whether the new admission is related to your previous admission or is completely unrelated, right? You can think of a patient, let's say, again, I work in cancer, so that's why my examples are in cancer. Like if a person is receiving some chemotherapy, and then you want to know if the readmission is due to that, or maybe the patient just fell and from a bike and then broke a bone, and that has nothing to do, and it will be really hard to predict that, right?
Right.
So So you will need to subset your data, and I don't know how. I mean, probably with how many million? I think you said 7 million nodes. Maybe that's possible, but but the other issue is that I don't know if you're treating here each node as a separate observation, or you're accounting for the fact that one patient may have many nodes.
So basically, in the entire encounter for remission, we chose the discharge node for prediction, because it is a summary of the entire visit.
But it's not by patient; it's by admission.
Yes, by encounter.
Okay.
Mhm.
Okay. Thanks. Yeah, no, interesting.
Yeah, thank you.
Yeah.
Thanks for the suggestion. I'll think more about it.
Well, thank you so much for the great talk and really interesting work. And thanks everyone for joining us.